Good evening, everyone. Our topic today is wound and wound healing. This pretest is on wound healing, so we can take this. I see that there are 18. There are 18 questions. So number one, let me start with number one. Which one of the following statements is true of the process of wound healing? A. It is composed of 5 key phases. B. Vasodilatation is the initial response after injury. Each of the key phases are distinct entities. D. Each of the phases are of similar duration. E. The wound healing process differs in fetal tissue. I'll choose E. The wound healing process differs in fetal tissues. So number two.
In the first 24 hours after a soft tissue injury, which one of the following represents the dominant cell type? 24 hours. The neutrophils, macrophages, lymphocytes, fibroblasts, myoblasts. Neutrophils.
Okay, number three. Any volunteer for number three, please? Number three. Which one of the following collagen subtypes is most commonly found in the skin? A type 1, B type 2, C type 3, 4 type D type 4, E type 5. So I'll choose A. Number 4.
Which one of the following is true in a 6-week-old healing wound? Net collagen production is positive. Net glycosaminoglycan production is positive. Net vasculogenesis is positive. Net glycosaminoglycan production is static. Net wait, which one? This is okay. Collagen at 6 weeks static. Choose B.
Okay. Number 5. Which one of the following collagen subtypes predominates in a 3-week-old healing wound? A type 1, B type 3, C type 4, D type 7, E type 9. So I'll choose B type 3. Number 6.
10 weeks after direct closure of wounds in the forearm, which push, which proportion of pre-injury tensile strength can be expected across the scan? 10 weeks. I'll choose C.
C or
Uh,
B. Okay, C. Okay. Number 7. Who is taking number 7 for us, please?
the patient sustains a wound to the right arm following trauma. After washout in the emergency department, the wound is left to heal by secondary intention. Which one of the following is correct regarding the effect of growth factors in the healing process? Fibroblastic growth factor will decrease fibroblast production. No. TGF beta promotes fibroblast migration and proliferation. Vascular endothelial growth factors produced by endothelial cells. EGF promotes endothelial proliferation. Folate derived growth factors promotes keratinocyte production. I'll go with B.
Okay. Number 8. Who is taking number 8, please?
Which one of the following cell types is chiefly responsible for reducing the surface area of a granulating wound because of its contractile properties? A. Fibroblast. B. Keratinocytes. C. Macrophage. D. Lymphocytes. E. Myofibroblasts. I choose E. Myofibroblasts.
Okay, thank you, Dr. Adam. Number 9. Which one of the following processes is an important cellular process that facilitates mobilization of keratinocytes during healing of a split thickness donor sites? Donor split thickness skin graft donor sites. A. Diabetes. B. Imagination. C. Loss of contact inhibition. D. Differentiation. E. Epithelialization. I'll choose C. Number 10.
Which one of the following reports accurately defines whether primary or secondary trauma caused by the neck? A. The mechanism of injury. B. The amount of tissue damage. C. The time healing takes to occur. D. The method of closure. How closely the wound edges are caused. I'll take E.
Number 11.
In which of the following conditions is normal wound healing expected after surgery? Progeria, runners, they are the same thing, adult and okay. Yeah, it's pretty laxer. You can operate them. So the answer is D.
Number 12, please.
Which one of the following vitamins can be particularly useful to help wound healing in patients on long-term steroids? A. Vitamin A. B. Vitamin D. C. Vitamin C. D, vitamin D, E, vitamin E. I think it's vitamin A, option A.
Number 13. What is the single most important cause of a wound to fail to heal? A. Poor oxygen supply. B. Denervation. C. Radiation. D. Poor nutrition. E. Dry wound base. I want to choose A. Number 14, please. Any volunteer of number 14? Yes, please.
Debridement of a chronic wound can remove excess granulation tissue and expedite healing. What else is thought to be responsible for impaired wound healing in chronic wounds that is removed during debridement? A. Metalloproteases. D. Latrogens. C. Myofibroblasts. D. Transforming growth factor beta. E. Chondroitin sulfate. I think it's option A. Metalloproteases.
Number 15, please.
You see a patient who wishes to undergo a facelift. She has given up smoking after your advice and now uses only nicotine replacement medications. Which one of the following represents a well-recognized effect of nicotine on tissues? A. Reduce oxyhemoglobin concentrations. D. Reduce platelet adhesion. C. Reduce local inflammation. D. Reduce local blood supply. E. Toxic effects on keratinocytes. I'll go with D. Reduce local blood supply.
Thank you everyone for volunteering. We can start the discussion proper. The plan today is to discuss wound and wound healing. Yes, so we need an outline for the discussion, please. Does anybody want to volunteer an outline? Okay, so let me give one. Yes, the introduction for the wounds and wound healing. So wounds on its own is a topic, and then wound healing is another. So for the wounds, I'll do introduction, then epidemiology. That's for the wounds. So the introduction includes the definition, then a brief statement of surgical importance, epidemiology, then the etiology, then the classification or types, and then the management. So for wound healing, we also define wound healing. We'll do it the way I'm suggesting, but we can refine it. We define wound healing, and then we'll talk about the phases of wound healing, understand the growth factors involved and all those. The phases of wound healing, then complications. Don't know if we find time, we'll just mention briefly something about hypertrophic scars and keloids. So we'll talk about complications, our local experiences, and then I'll conclude. Okay, so this is my
Uh,
outline. Please, any corrections, contributions, suggestions as to how we can adjust it and discuss the topic easily. So if there's no suggestion, we can start discussion. Who is willing to take introduction, please? Okay, so let me start. Let me define a wound. Let me take the introduction, define the wound, and then we'll talk about the wound healing. So a wound is defined as breaking integrity of a tissue that may be associated with disruption of structure and function. So as surgeons, wounds are common things we see, we manage. They come in different forms to us as surgeons, both those are the acute wounds, the chronic wounds, as plastic surgeons. And most of the time, when they are complex wounds, the a consult is often placed to us. As we'll see subsequently in the discussion, we'll see that there are different causes, etiologies of wound. Why the wound healing on its own is an orderly is the process by which the body tries to heal itself following an injury. Usually an orderly process, even if there are different phases, but all of them occurs kind of concurrently. So an adequate knowledge of the knowledge of wounds, their etiology, as well as the management would give us a good outcome whenever it occurs, because sometimes simple wounds, when they are poorly managed, can become chronic wounds, and that can become chronic wounds that will cause significant morbidity to the patient. Once in a while, some of these wounds can actually lead to mortality. So it's good to understand the knowledge and the principles of how all these, the principles of their management, as well as the principles of management, so that we would get good outcome whenever we take care of patients that have these wounds. So this is what I have under the introduction. Please, do we have any contribution to these additions, corrections? Thank you.
I don't know whether as a part of the introduction, Well, is it the definition you just gave or introduction generally?
Yes, I added introduction, but you can actually make adjustments, corrections. I
Okay.
think yes, you can.
Okay, my own contribution is that apart from it being a breakage in the integrity of tissues, it's also important to add that that the etiology could be either infectious, traumatic, um, inflammatory, etc. You know, I don't know whether it should form the a part of introduction. That's just a contribution anyway. I don't know.
Okay,
Thank you.
thank you for that, Dr. Joachim. Thank you for that. Please, do we have any contribution before we move to the next phase?
I was asking, what is the dividing line between a wound and an ulcer? Can it come in the definition? I don't know if you could hear.
Yes, you're asking that what is the dividing line between a wound and an ulcer?
Yes,
Whether we should include it here.
yes, definition.
Okay. You want to contribute that for us, please? Or you're not sure too?
Well, actually, I am not very, you prepared. I'm ready. But
Okay.
some people say that maybe an ulcer may have elements of inflammation or some other things. Maybe you can just fine tune it.
Okay, then ulcer will have an element of inflammation.
Yes,
Okay. Okay, which a wound do not have.
yes. But
Okay.
it's been a long while. I checked it up. I can't remember exactly the dividing line.
Okay, no problem. Since we are seven here, maybe other people will have. What do we think? Ulcer and wound. Some places you see wound and injury.
Please, sorry, from the definition, I thought that ulcer also falls under wound because there's a definition I've seen that says wound is a break in continuity of skin or soft or tissues in general. So I don't know.
Okay, the ulcer and wounds are not the same, but ulcer can be part of a wound. There are some clear definitions. Wound is more like a disruption in the structure or function of a tissue by definition. Uh, and it can involve any type of tissue, but ulcer most often is limited to epithelial lining. That's why the definition comes in discontinuity of an epithelial lining. So there are two clear differences. An ulcer can be a wound, but
Chief, that's what
you
I was trying to say. I thought that an ulcer is a type of wound.
thank you.
Yes, thank you for that contribution. Please, do we have more comments on this? Ulcer, wound, injury.
Sorry, I don't know. I couldn't hear Marshall very well. So I don't know if I'm going to be repeating what he said.
Yes, he mentioned that an ulcer is discontinuity of epithelial lining. So that's as distinct from a wound, which is a tissue, discontinuity of tissue. So he's inferring that an ulcer is a type of a wound. It's just a since it's epithelium, yes, it's a subset of a wound.
Okay, let me just say differently. A wound is a breach in the structural integrity of tissues. So they may not be a discontinuity per se, but the structural integrity is affected. While an ulcer is a breach in the continuity of epithelial lining. So all wounds, all ulcers are wounds, but not all wounds are ulcers.
Thank you. Please, do we have any? Thank you for all these comments. Any other contribution on this?
What of injury? We haven't given an explanation to that.
Okay, injury. Yes, the only place I saw for injury, they talk about wounds to be that wounds are kind of more superficial. Wounds are superficial, while injury it's more broader than wounds. So for injuries, we can have even other when we have other internal organs, like say the chest cavity, abdominal cavity, other structures there. Unlike for wounds that refers to even the tissues. So most of the time, most of our wounds, when we talk about our wounds, we refer to skin, anything that will affect skin, subcute, facial muscle, bone. But when we start talking about visceral damage to the viscera, we talk about injuries. So that's what is there for different between. So injury is more broader than wounds, and then wounds is also broader than an ulcer. If we talk about what they contain like that.
Okay. Well, my own understanding of injury, it's these are effects on tissues that often results from a flow of energy. That is the way I see it. Maybe the energy could be either a physical energy, chemical energy, or energy of substance, but it's more of transfer of energy of any kind to the body to disrupt the integrity of the tissue. That is the way I see injury. Thank you.
Thank you, Dr. Joachim, for that. So any
Hello?
other comment before we move to epidemiology? Did we see any figures, please? Okay, etiology. Who wants to take etiology? Please let's move to the next thing.
Etiology can be grouped into three basically: mechanical, infective, and chemical. So, under mechanical, the normal trauma either from road traffic accident, machete gun, blast injury, gunshot injury, also from burns. So the chemical can be either an alkali or an acid, an alkaline or acid that caused the injury, or any other forms of chemical injuries. Then the infections can be infective from our nicotizing fasciitis to diabetic foot and to so many other infective causes. Borrelial ulcers, all those can lead to wound, any form of infections. Then at the extremes, something like frostbite from cold is also a kind of burn injury. That is basically the etiology. I
Thank you,
don't
Dr.
know.
Marshall, for that. Yes,
Okay.
thank you. Please, other contributions, please. Etiology. Okay, so let me take the classification. So the classification of types of wounds based on the wounds can be classified as open or closed based on the integrity of the surface epithelium. So in the closed wounds, the epithelium, there's no communication with the exterior. While for the open wounds, there's disruption of the epithelium and other layers such that it communicates with the exterior. So I'll further subdivide this later. Then it could be, so that's for open and closed. Then we could have an acute wound or a chronic wound. An acute wound is a wound that's usually based on timing. Wounds that occur less than 6 weeks are acute wounds, while chronic wounds that have lasted for more than 6 weeks, when they are properly cared for, are chronic wounds. Then the other classification, the rank count, there's one classification according to rank and Wakefield classified wounds into tidy and untidy wounds. A tidy wound is a wound that is a clean wound caused by a sharp object. Usually the edges are regular, there's no tissue loss, and sometimes the level of contamination is not so much compared to an untidy wound, in which the edges are ragged, there's tissue loss, there's contamination, level of contamination in the wound, and then it's not caused by maybe caused by blunt trauma, crush, or other things that will cause the vitalization of the tissues. Then, based on the level of contamination, we have degree of contamination. We have the clean wounds, clean contaminated, contaminated are dirty. So clean wounds are surgically incised wounds in which no hollow viscous is entered, and then no hollow viscous is entered, and then there's no breach in asepsis. So while for the clean contaminated, this one the degree of infection, the risk of infectivity of those wounds is less than 4%. 4%. Then we have the clean contaminated wound in which a hollow viscous is entered under sterile conditions. However, with minimal spillage of intestinal content. So the example of all those clean wounds that we mentioned that we don't enter any hollow viscous, like lipoma, mastectomy, all those excision biopsy for some superficial lesions. Why for the clean contaminated? So if there's spillage in a controlled, if there's minimal spillage or spillage occurs in a controlled environment, that's for the clean contaminated. So examples of clean contaminated wound, we have our elective appendectomy, and then if we are doing cholecystectomy for gallbladder surgeries. So those are some examples of clean contaminated. Then contaminated wound is one in which hollow viscous is entered, maybe gross spillage of contents. Understand, hollow viscous, gross spillage of contents, and then gross spillage of content, but there's no active infection present. There may be infection though. So that's for the contaminated wounds. So our traumatic wounds, the early traumatic wounds that just come in, they fall into the class of contaminated wounds. Then our acute appendicitis, it's also here for the contaminated wound. Then we now have the dirty wounds. Apart from the fact that we already mentioned, see this one, there's obvious infection, mid pus, obvious spillage, feces, and then our traumatic wounds that come in after 8 hours, because those ones that come in early are contaminated. Those that come in after 8 hours or after a day, they are already dirty wounds. So that's just some, and the risk of infection for the dirty wound is greater than 40%. So that's it. So now for the open and closed wounds, the example of closed wounds are the bruise or contusion. So contusion is defined as injury to the structures that are beneath the epidermis, subjacent to the epidermis. So usually a contusion will lead to what we call, there'll be bleeding under the skin, but the epithelium is intact. If depending on, it can also cause hematoma because of the bleeding. But once the area of blood that is under the skin is more than 1 cm, it's called an ecchymosis. So that's for the closed wound. The example of closed wound, the contusion or bruise. Then the open wounds. Open wounds could be an abrasion, which is just the just the surface epithelium that is damaged for abrasion. And then we have a puncture wound that is caused by a sharp pointed object. The width is usually small because it's a sharp pointed object, small compared to the length, the depth of the wound, but it's full thickness tear compared to an abrasion, full thickness skin loss compared to an abrasion that is just the epithelium that is affected. Then we have the laceration. Laceration, full thickness skin loss caused by blunt trauma. The edges are ragged because of that. Then we have some people talk about in the incised wound itself. Then apart from laceration, we have other things like avulsion. Avulsion is when a part of a tissue is torn. When its tissue is torn, a body part is torn. It could be partial avulsion when part of it, even though it is torn, it is still attached to the body, or complete avulsion when there's total loss of that part. But in the complete avulsion, the bleeding is likely to be more in the partial avulsion than the complete avulsion injury because of the hemostatic vasoconstriction and hemostatic mechanisms are more would be able to occur when you have a complete than when you have a partial avulsion. We have other things like the gloving injury, when a tissue is injured along a predetermined plane, for instance, between the skin and the subcute, or exposing the muscle, the skin and subcute, or skin and fascia, exposing the muscle. So we have the gloving injury, and there's some classification for the gloving injuries, whether there's one Annex classification, but there are some other classifications for, I think the one I know is the Annex classification for the gloving injury, whether it is non-circumferential, whether it is circumferential, then whether it is multiplanar. There are four. I think when I remember it and I'll say it before I finish. So I talked about um, then crush injury. Crush injury occurs when a tissue is compressed between two surfaces. Usually for crush injury, there's tissue loss. The damage is so much. Would have skin loss, muscle. Sometimes there's even fractures accompanying it. But usually the tissue, the skin, and if it were care is not taken, it can lead to crush syndrome. These are some examples of open injuries we have. The others are penetrating injuries, perforating injury. Whenever it enters the body cavity, is a penetrating injury. Some people talk about the fact that when it has entered the hollow viscous, there's this thing about penetrating injury has entered the body cavity, perforating when it has entered a, for instance, the chest, the abdominal cavity, and a hollow viscous perforation. And then we have the true and true. Maybe it's going through the limb. So we have either a stab that goes in through and through, has an entry and exit point. There are other wounds, gunshot wounds, blast injuries. All those are on the other types of open wounds. Thank you. Any contribution under classification, please? Classification or types. Other contributions are welcome. Thank you.
In addition, it can be classified based on etiology. So where you have like burn injury, burn wounds, infective wounds, traumatic wound, gunshot wound, and so on. That's what I wanted to add.
Okay, thank you, Chief Marshal. Please, other contributions, please.
Sorry, I want to ask something, Dr. Eunice.
Yes, sir.
On that acute and chronic, what you said is used for ulcers. I don't know. I saw somewhere where they use time using 8 hours and to be a benchmark for division. I think I saw that thing in SRB.
Okay.
Where they say
So
for
anything that's
wounds
more than 8 hours.
is not a chronic wound.
Wow.
Once you transcend above that, you now start thinking of ulcers.
Some people, apart from this timing, actually, as you said, could be
Mm,
controversial. Some people
yeah.
talk about wounds that have failed to progress through the orderly phase of wound healing. Some people use this definition. Any wound that's failed to progress through the phases of wound healing, usually they will now add time, usually
Mm,
after a period of, but 8 hours, I've actually not seen that. But in fact, that 8 hours, that's contaminated and dirty. You
yeah.
get so if it's 8 hours, because there was this golden rule before, but for acute and chronic, 8 hours is in fact wound healing, inflammation has not even finished.
I was surprised when I saw it.
Mm.
I just wanted to share it in the platform.
Okay, thank you, sir. We can move to wound healing. There's an outline on ground. We can
Okay,
modify
okay,
the out. We can let me read out the outline. Where to define wound healing, talk about the
okay.
phases of wound healing, the factors affecting wound healing, then the
Mhm.
complications, local experience, and conclusion.
If you talk about definition, I think we should talk about types of wound healing, then intentions of wound healing, and then now goes to phases of wound healing. Then we look at now the factors that affect wound healing, and now go for the complications. Then the other one. Don't
Okay,
you think
thank you.
so? Let me take the definition now.
Okay,
Wound healing is body response to injury in order to restore structure and or function of the injured tissues.
thank you for that
Uh,
definition. Yes. Do we have any other contribution to that? Okay, so we can move over to the types of wound healing. For the types of wound healing, we have primary wound healing. It still looks like the intentions of wound healing, but primary wound healing, secondary wound healing, and then delayed primary wound healing. So the primary wound healing is the healing that occurs when wound is closed immediately, when the edges after an injury, a wound occurs, the edges are approximated together. While the secondary wound healing is what we see when wound is allowed to heal by on its own. Sometimes people do it when there's some form of tissue loss that would prevent immediate closure of the wound. But delayed primary wound healing are those that after debridement will now close. So it's still similar to those our intentions of wound healing. So those are the things for the types of wound healing: primary, secondary, delayed primary. Any additions to that, please? Okay, so what are the intentions of wound healing?
Sorry, what you just described, I'm wondering, are they forms of are they like intentions or are they like closure, forms of wound closure? Something like primary closure, delayed primary closure, secondary closure.
It's sounding like that, but some people still categorize as types of wound healing. The next thing we are going to talk about is intentions of wound healing. So we'll mention all those, and then the closure, we'll still mention it. Secondary wound closure is different from this secondary wound healing, because this secondary wound healing now is tending towards secondary wound healing is tending towards healing by secondary intention.
Yes,
Do you get? Not
yes, yes.
not secondary closure.
Not secondary closure, yes, I understand.
So that's it. So is some books you see types of wound healing. We mentioned primary, secondary, and delayed primary
That is
types.
intentions of wound healing.
Okay. Okay, so what are the
You
types you wanted to mention?
the types of wound healing is basically two: the repair and regeneration. Then in repair, you in regeneration, which is common in other organisms like earthworm and other hydra that regenerate very well. And liver try to do that. But basically what happens is replacing like with like, where the parenchymal cells replace itself. But in the repair, which is common in human and other high mammals, is more like healing by fibrosis and scar. And that is basically the way our wound healing goes. That's why at the end you need to have your remodeling when you go through the phases. Then that healing intentions of wound healing is basically a subtype of the repair, tissue repair that takes place in high mammals.
Okay, thank you for that contribution, Dr. Marshall. There's a
Thank you.
heading like that in Essential. So Essential, there's a place for types of wound healing as primary, secondary, and delayed primary, as different from, you understand. And so
Okay.
sometimes, yes, but sometimes all these are headings. You put it, and in case we are asked, we should have an idea. How that this. Some people also see this regeneration and repair as how lost tissue is replaced by different organisms. Some are able to regenerate, some cannot regenerate, and then they'll have to undergo the processes of wound, and they'll have to replace by fibrous tissue because they've
By
lost.
collecting tissue.
Yes, because they've lost their capacity to regenerate. Yes, thank you for that contribution. So let's talk about the intentions of wound healing.
You have said it now, madam.
We've not said it. We've not said it. We just mentioned. We just talked about the heading. Yes, healing by primary intention, healing by secondary intention, healing by tertiary, healing by quaternary. Is that what we meant by that outline?
Yes,
Yes. Yes. Okay.
uh,
Primary. Yes. So please, who can?
primary intention.
So the healing by primary intention. So let me say it. Then healing by primary intention is healing that occurs in either a freshly caused wound or an incised surgical wound where there's no tissue loss, and then the edges are approximated nicely. Usually the aim is that we should get a hairline scar. So healing by primary intention is the one that we do for all those with no tissue loss. Then healing by secondary intention is healing that occurs in wounds in which there's tissue loss. And sometimes granulation tissue, there's also formation of granulation tissue accompanied by that. So the problem with healing by secondary intention is that the scars is not as excellent as when we have healing by primary intention. Then the healing by tertiary intention is what occurs when we do delayed primary wound closure. That's healing by tertiary intention. Is is the healing that occurs in wounds that ab initio at presentation are suspected to be contaminated or infected, or whose level of contamination is not certain. So those wounds are dressed and then eventually closed after a period of 3 to 5 days when the inflammatory phase would have elapsed. So whenever we wait for that before we close a wound, that closure is delayed primary wound closure, and the healing that occurs in that is healing by tertiary intention. Now, the healing by quaternary intention, I think I'll say it, and then I have had two versions of that, and I want us to comment. The healing by quaternary intention that I know before is the healing that occurs in a donor site wound. A donor site wound where it is purely by epithelialization, because it's just the superficial part of just the epidermis and part of the epidermis and part of the dermis that is taking over. But I also had another place that healing by quaternary intention is healing that occurs in skin grafts and where flap is used to cover a wound. Once a wound is helped by putting something on it, that is healing by quaternary intention. So what do people think about that? So these are, I have these two for healing by quaternary intention. I don't know what we know as healing by quaternary intention. Thank you.
Okay, what I used to know is the first one, healing by reepithelialization, like
Okay.
superficial
Does
burns.
anybody have okay? Okay. Does anybody have any contrary? Has anybody had that healing by quaternary intention to be those healing that is seen in what's the name, skin grafts and flap? Unfortunately, it's, from some of our stuff is oral, word of mouth, oral tradition. I've not seen it in a text that will say I read it here. So that's the problem.
So
Yeah,
I've read quaternary.
You've okay.
oh,
Once you can give us a reference, that would be
I,
excellent.
yes,
yeah,
please.
I will.
Yes,
I will check.
please give us
I've
a
seen
reference.
quaternary in a textbook.
Okay,
Okay.
that's fine. Once I see that, Dr. Joachim, you have a comment?
No, I wanted him to give us a reference of that quaternary wound healing because I've searched for the definition and I haven't seen it even in any standard texts. So kindly share, uh,
I will.
your
I will.
glad to.
It's
Yes,
in the
thank.
test.
Okay.
Okay, so Doctor, do we have other contributions here before we move? Dr. Sadiq, are you saying something?
Yes, I also I also came across our oral tradition. Those things, those two definitions we give. Well, it's actually in this current center. That was the first time I was coming across that one that they said wounds that have been closed by either graft or flap. But the one I knew ab initio before I joined plastic was the one that happens via re-epithelialization, especially in donor site wounds or deep dermal or superficial partial thickness burn wounds like that. So
That's what happened to me too. I was looking like the
yes.
odd one out when I said that one. I know.
Yeah, there's something one of our guys here was saying about this intention. He tried
Yes,
to make it in such a way that the criteria is timing and granulation tissue. So those are the two criteria we look at when we're trying to define this intention in terms of time. So he said that in his intention, it's closed almost immediately within 24 hours, so there's no granulation tissue. So timing less than 24, within 24 hours, then there's no granulation tissue whatsoever. So in the late primary, the wound is closed within 3 to 5 days or before the formation of granulation tissue. So usually within like that 3 days. It's
What's
just
going
allow
on?
the
I can't
wound
hear
to.
anybody.
Hello.
hi, Doctor. Yeah.
There is a common question: delay primary wound closure and secondary wound closure. There are some definition attached to it, and there are some time bound attached to it.
That's what he
For
was even telling us. before his network started. But you can go ahead.
The delay primary wound closure. The primary problem is either edema or contamination that you want to give time to clear them off and resolve. Allow your wound now to close. So there is absence of granulation tissue. Standardly, apart from our 3 to 5 days, in some tests it has extended to 10 days. By then, granulation tissue wouldn't have formed very well, so wouldn't have formed. When you do secondary wound closure, two things happen. Either it's highly infected wound or contaminated, or wound that is so deep and highly exposed. You want to buy time for it to contract through the activities of granulation tissue, and then you can now close. You allow some level of granulation tissue to form. Time frame is above 10 days to 14 days.
Thank you, Dr. Marshall, for that contribution. Thank you. Yes, Dr. Sadiq, can you greet us?
Ma,
Okay. Yes, you can go ahead, please. You were trying to tell us something.
I think it's just similar to what he just said. It's just that the timing.
Okay.
What this one they said the delayed 3 to 5, while above 5 does the secondary wound closure. Like I said, the criteria is timing and granulation tissue. So for primary, within 24 hours in terms of timing. For the late primary, 3 to 5 days. For secondary, after 5 days. Then the granulation tissue. For primary, no granulation tissue. For the late primary, no granulation tissue. While for the secondary, is when granulation tissue would have started forming or would have formed before we close. So that's the description one of our guy gave here. Like I found it in textbook or anything.
Thank you. So, Dr. Marshall, you want to say something?
Yes.
Yes, please.
Okay, so like what I said, I found it in a textbook.
Yes. Dr.
Mm.
Marshall, you've promised us the reference now.
I think it's principles of wound, practice and principles of wound.
Okay. Please, when you are setting, help us put it on the group, either the Telegram group or the WhatsApp group.
Okay,
Thank you for that. Thank you. So we'll move over to the phases of wound healing.
let me try.
Thank you, Dr. Marshall.
We have three major phases, but some people try to divide it into four, separating the inflammatory phase into two, the inflammation and the hemostatic. Then, but still the same if you take it as three phase in most of the standard textbook: inflammatory phase, proliferative phase, and the remodeling phase or maturation phase. The proliferative phase is also known as the reparative phase. Then the inflammatory phase is also known as the reactive phase. Series of events takes place in each of these phases, but they overlap. They go on simultaneously, but with little differences. The inflammatory phase, one you look at the vascular event and the cellular event, basically. That's what happened there. Then in the inflammatory phase, the vascular event, one initially you have an injury. There is this analogy that gave, I think, in 2018 lecture in Jos, where you have a house and all of a sudden destruction came upon the house. Most of the leaky pipes and everything. So during that inflammatory phase, the hemostatic phase, you try to curtail those things. Initially, you have a transient vasoconstriction. That transient vasoconstriction will occur if the damage is not so severe, it's minimal. It may last like 3 to 5 seconds. But if it's severe, it will last up to 5 minutes. Then following that, you have vasodilatation phase that increase blood flow to the system. And that is what is responsible for the warmness of the injured area and the redness that you feel. That is progressive and persistent until at a point you experience stasis, because as more blood flow in, there will be stasis, and that stasis will lead to platelet adhesion to exposed subendothelial tissue, collagen, and that will now subsequently trigger the coagulation pathway and finally form a permanent clot. And that clot, the essence of it is one, to seal off the leaking vessels and also form a scaffold for migration of tissues that will be involved or cells in the healing. So that seal off also gives a protective end and ward off that injured and exposed area that is communicated with the environment and also shield from infection. Then at that level that this occur, what we now have is the cellular event that will take place. Once the clot is formed, the platelet will secrete the platelet growth factors that will stimulate other cascades of inflammatory response that will finally transcend into the cellular event that will take place. At that cellular event, what happens is actually one, due to the blood flow initially that was on, you will notice that the axial blood flow will over time change. Initially, the cells are centrally located in the blood flow, but as more blood or as viscosity of the blood increases, you find out that most of the cells will now move to the periphery because the volume of the plasma have reduced due to uh, trans due to the transudation that takes place. Some of them will go out into the tissue, interstitial tissue, and all that. So that reduction will allow cells to now come to the periphery, and that is where margination and pigmentation takes place. First, the white cells now try to uh, move to the periphery. So what is happening now is margination that occurs. Then over time, as it increases, they get the movement decreases the more. So they get pigmented to the peripheral area, taking them closer to the site of injury. And at that point in time, the cells will begin to roll and adhere via the seletins molecules, immunoglobulins, then the seletin that are found there, the platelets, those ones that are found in the platelets, and those that are found in the endothelial cells, which is the P seletins, will allow them to adhere, but the adhesion at that point is not firm. They keep roll. But when they are able now, the endothelial secreted seletin, the E seletins, will now allow it to adhere better and it became more firmer. But there is a particular seletin that is secreted by that is exposed on the walls of the platelets that allows it to stick better and adhere. At that point of adhesion, it becomes permanent. It will stabilize within the sub-endothelial cells collagen that was exposed. And once the cells were able to adhere, they now need to migrate. And they migrate towards through the walls of the vessels and get somehow entrapped between the basement membrane and the outer walls of the vessel. So at the basement membrane, they are able to secrete some collagenase that allows it and allows it to move uh, away from there. But before that happens, it's not that there is a cut line or a demarcation between those. It's an overlap process. So what else that will happen will now take us to the proliferative phase, where the chemoattractants now cause these cells to move into the interstitium. Those chemoattractants like leukotriene 4B, activated C5 and C3, and even some of the um, uh, um, uh, these some of the peptides secreted or polysaccharide peptides secreted by organisms, bacteria, will also attract those cells. At that point, the first cells that move into the intestine becomes a neutrophil, and the neutrophil, and subsequently the macrophages that will now go in and try to debride the tissue, devitalize tissue, these things, and mop it up through phagocytosis. Hello?
We can hear
Hello?
you. We
We
can
are
hear you.
following you gradually. Oh. This our we are heal the wound is healing gradually. We are following you, Dr. Martha.
That proliferative phase, the macrophages in place, which is the key cells there, will now stimulate and cause the release or the presence of fibroblasts that will come in to synthesize collagen, and subsequently also that the activity of the macrophage will also stimulate so many other cells uh, and other growth factors that will come in to aid in producing collagen and the extracellular matrix, those ground substances that will not be laid, and subsequently when those collagen are laid and produced, and gradually the cross leakages that will now take place. There are so many details there. So for want of time, let's progress. Then basically the maturation phase now comes in, where the key cell in maturation phase is the myofibroblast. So the uh, metalloproteinase and tissue inhibitor of metalloproteinase now try to balance the degradation and the synthesis of collagen at that point, so that it will now stabilize it, and subsequently other tissue remodeling and maturation takes place until, which they say it takes about 1 year or thereabout. Then the time frame to each of them, the inflammatory phase is 24 to 48 hours, while the proliferate phase is about 72 hours to, is it to a week? Can't remember very well. And then no, 72 hours to 20, no, I can't remember very well. Please, somebody should help me with those time. Then I think I rest my case. Others can contribute.
Thank you, Dr. Marshall, for that contribution. Yeah, so we are still under the phases of wound healing. Do we have any? Dr. Marshall has taken us through the phases, told us about that there are 3 or 4 phases. Some of our books you see 4: the hemostasis, inflammatory, proliferation, and the remodeling or maturation. So there are key things. There are actually so many molecular things there. Yes. Does anybody wants to contribute here, please?
Okay, Chief Ono.
Yes.
Okay, so for these phases of wound healing, just a little comment. It's actually phases of wound healing. It's different from stages. It's not stages of wound healing. It's phases of wound healing. Then, secondly, the that analogy to the house that is on fire or house that is on fire, yes, is not analogy. It is an analogy that was described by a man called Dean Kane. Kane. So it's called Kane's analogy. It's in the books. It's all over the place. You get, so it's called Kane's analogy. So what he tried to do was he compared these phases of wound healing to what happens when a house is on fire or a house is on fire. So the first thing you do is you go and block all the utility, pipes. The gas pipe you block it, the water pipe you block it. You switch off the main and all those things. That is what hemostasis is about. You want to stop bleeding. You want to stop further bleeding. So that is what happens in the first phase. Now, the second phase is that you now start cleaning up the rubbles Okay, so the rubbles from the house, you start cleaning it out by unskilled laborers. So those are the macrophages, cleaning out the debris and the contaminants and the devitalized tissues in the area. That is the second phase. Then the third phase, you now have skilled workers now laying down the blocks. The masons will start laying the blocks, they'll plaster, the plumber begins to, fixing the plumbing work, the carpenter begins to do the woodwork. That is the fibroblast doing their work now. Then the fourth phase is the remodeling, where you now start doing your interior decoration, your finishing, your painting, and all those things. So that is Kane's analogy of wound healing. Okay. Now I want to just add to that. Yes, there's so much details to it, but there are some essential points that should come out when you're discussing it. Now, when you have the platelets coming, the platelets will degranulate. Part of what they form, they release some cytokines. The most important of those cytokines are interleukin 6 and interleukin 8. Those two come in and they are the triggers that cause macrophage and the other immune cells to come into the wound. Interleukin 6 and interleukin 8. Now, macrophages in turn now produce growth factors and some other cytokines. Now, very important amongst those growth factors are transforming growth factor beta, especially subunits 1 and 2, then platelet derived growth factor. These are the most important ones. They also produce epidermal growth factor as well as vascular endothelial growth factor. Now, this platelet derived growth factor and transforming growth factor beta are chemotactic factors for fibroblasts to come into the wound. The strongest chemotactic factor is platelet derived growth factor. Then transforming growth factor beta is the strongest activation factor for fibroblasts. So fibroblasts now begin the process of fibroplasia. So the proliferative phase has three distinct features: fibroplasia, epithelialization, and neovascularization. Those are the three things. So fibroplasia, you begin to lay down collagen and the extracellular matrix. Then vascular endothelial growth factor causes neovascularization. Then epidermal growth factor now causes marginal epithelial growth. So those are the things that happen in this phase. So the subsequent phase is the remodeling, which I think I'm okay with the way it was discussed initially. Then remember that the fibroblasts now acquire actin, now change to a contractile phenotype known as the myofibroblast that now causes wound contraction. Thank you.
Thank you, Dr. Uzoho, for those contributions and clarifications. Thank you. So it's Kane's analogy. So thank you for that. Do we have other contributions here? We've not mentioned which collagen we have first, before later we'll now have other collagen. Remember that in the fibroplasia, the collagen, everything is haphazard. And then before in the remodeling, everything will now be arranged orderly. So we have our type 3 collagen initially, that in the maturation / remodeling phase becomes type 1 collagen. So thank you all for these contributions. That platelet degranulation, in fact, so important. So because we'll be wondering what's the role of platelets, but they really play a big role in wound healing, because that's where everything starts from. It's when it degranulates that all those things come, and then apart from our neutrophils, our macrophages, like that. Thank you all. So Dr. Joachim, you want to add something, please?
Yes, I know that the collagen has a ratio initially, and there's a ratio reversal. I can't really remember the ratio, whether it's 4:1, and there's a reversal of that ratio. That's in terms of the collagen ratio of collagen type 3 and type 1.
Yes.
Thank you.
Thank you. So Dr. Joachim is contributing that initially we have a preponderance of type 3 collagen, and then subsequently it will now be type 1 collagen. Thank you, Dr. Joachim. Can we move over to the factors affecting wound healing? Dr. Ada, you want to give us that? Or is it Dr. Bolaji, Dr. Pascal, Dr. Joachim, Dr. Onu, Dr. Chibuzo, Dr. Uzoho? The factors affecting wound healing. So anyhow you say it, somebody will add to it, please. So feel free. The local factors, the systemic factors, factors affecting wound healing, please. Who is taking it, please? The factors affecting wound healing. We have local factors and we have systemic factors. So the local factors that affect wound healing include infection at the site of the wound, foreign body, and then radiation. Then we have moisture. If there's no moisture, the wound is desiccated. All those things can affect it. I mentioned radiation too at that side. So those are some local factors. The systemic factors could be genetic. As we mentioned, we see some genetic conditions that can affect wound healing. For instance, those that have syndromic conditions like collagen defect, as we see in those that have Ehlers-Danlos syndrome. Those are some genetic factors that can affect wound healing. So the other types, then in fair skin people are prone to having finer scars than the dark skin people. Then the other systemic factors that can affect wound healing could be medications like steroids. Steroids will dampen the inflammatory phase, and then smoking can also affect it via that because of vasoconstriction or because of the nicotine in it, or because of reduced oxygen delivery as a result of binding of oxygen to carbon monoxide. So then other systemic factors, those that have poorly controlled comorbidities, poorly controlled diabetes, immunosuppression, all those things can are systemic factors that can affect wound healing. So those are some things that can affect wound healing, the local and the systemic factors. We can contribute, please. Nutrition is also part of the systemic factors. Protein deficiency, and all those are vitamins, vitamin deficiency. So all those ones are also important. Okay, complications, please. We can talk about complications of wounds or complications of wound healing. They are all complications under this topic.
Let's take it one so that everybody will contribute. Infection.
No, from wounds we can have ischemic gangrene, amputation of the limb if it is not properly taken care of from the acute traumatic problem itself. Then
It can be
infection, yes.
infected, yes.
Yes, thank you.
Abnormal scars, like
Yes.
apoptosis scar, keloids, chronicity.
Please, other contributions before we close, we'll soon round up, please. Lymphedema, malignancies can occur, especially in the chronic wounds. We can have Majolin's ulcer, which is a malignant transformation of a chronic wound. So you've already mentioned hypertrophic scars and keloids, hyperpigmentation or hyperpigmentation, all those colorations, even the contractures we have are also complications that can accompany wounds and wound healing.
Suture tract.
Sir?
Suture tract.
Yes, thank you. If we don't remove it earlier, suture tracts. Thank you. So those are some complications of wound healing. The management of wounds, we've already mentioned it, that it is broad and it depends. So we'll check it up since time has
So, sorry, is it what we call it suture tract? Is it what we
it's
call it?
not suture, is it suture
Suture,
marks? And is either suture tracks or suture, one of them. I'm not
is it
sure.
tract? Okay, I know it has some names like hatch mark.
Is it the red tract?
It's hash mark or tram track or scientific scars.
Are we talking about the same thing, Dr. Ozo?
I don't even know if we're saying the same thing.
You know
What are you
those
describing?
those marks, if you don't remove sutures early,
Uh-huh.
especially when it now cuts through, yes. When you don't
So,
remove it early, you now
that's
be
what
seeing it.
that's what we're saying now. I don't know. I
Um,
don't know if I've seen it called suture track, but I know if they call it hatch mark or tram track or certificate card.
It's still constitutional track. Then you have other names to read.
Okay.
okay. Mm.
All right.
No, that there are so many textbooks, so it depends on where you read. And so that's why we're
Oh,
actually having a discussion, so that anybody sees anything, you tell us. We'll now add it to our compendium of stuff and knowledge.
okay.
Yes, thank you all. Mm. Yes. So local experience, we can skip it, or should we do we comment on local experience? But the local experience would have been when we talk about management of wounds, the management, then what we do locally for different types of wounds. I know wound people vary. Some places they do, especially for all those wounds that are contaminated, those crush injuries, those wounds, they do first look, second look, third look, and all those look. While others, maybe if there's no space, they will debride very well and close. So different practices depend on pressure on the facility and then manpower. Mm. So different practices. So do we have any comment on that, please? The local experience. Is there anything we've not mentioned? I was thinking that this keloids and hypertrophic scar, maybe one day or in our picture test, we'll now talk about it, because keloids and hypertrophic scar, they are topics on their own with the management, but we may not be able to do it today. What do you guys think? Because under keloids, there are theories, those are short cases. But I know our picture test have it. So maybe we'll read it up. It's supposed to be part of this topic. We'll read it up so that one of those days we'll now maybe discuss it with the treatment options to be in one of our picture slides when we study. So we'll take note of that, please.
Can't we take it as a topic? Because I've seen one question on, um, I think essay question on
Yes. Wow.
either keloid or hypertrophy, any of that.
We can. Anyway, since this is a
Uh,
principal topic, one of these Thursdays,
mm,
Thursdays are for our principal days, either we are doing a topic, long case or short case or picture test. So I'll jot it down somewhere. Yes, in our next round, probably it will be
mm.
a follow up. Yes, when we've gone round maybe the next Thursday now we'll do a long case by God's grace. So when it's time for a topic on a Thursday, we'll do keloids and hypertrophic scars so that we'll dissect it. Mm. Thank you for that suggestion, Dr. Marshall. So we quickly do the post test and we conclude. But is there any other comment on this topic before we go to the post test? Any other comments?
Okay, I don't know. When I joined, I didn't listen to the outline you gave. Is there anything like uh, current concepts in wound healing in that outline? I don't know
Oh,
whether it's important
there,
to add
there,
it.
there- it is. Thank you for that contribution. It is.
Okay, things like the role of the extracellular matrix and even all those uh, stem cells, that their role, growth factors, stem cells, their role in wound healing. Thank you.
Thank you, Dr. Joachim. Thank you. Then there's this time management, time, that when
Time
we talked
concept.
about time concepts, yes, thank you for that correction. The time concepts, that whenever we are discussing management of wounds, we should remember. You get so when if we had talked about the management, we would add it. the time concept. So that's the tissue management, and that's the fundamentals of wound care, the summary. So T is tissue management or debridement, I is infection control, M is moisture balance, and E is edge advancement. So with that, we can have a, when they tell us that we should talk about sometimes there was a question they were saying, discuss the current concepts in the management of wound care. Is it current concept? Yes. So some people were saying what the answer they wanted was just the time, while other some of us were just writing other things that we know about negative pressure. Although that essay I wrote it and I never got my script, so I don't even know what the examiners wanted. But one of my colleagues was whispering to me that it's time concept that they wanted us to talk about. So I don't know. Dr. Marshall,
Ma,
if you see a question, discuss the current concepts in the management of wounds, in wound management, what will your mind go to?
there are so many things. The time
Okay.
concept per se is a kind of principle guide. Because if you look at current concept in wound management, there are so many things that is ongoing in terms of wound management, even the dressing agents, the stem cell that he talks about. You know, my work is on platelets.
Yes.
So those things are current things. Just like when we are discussing wound healing. If you are going to platelet, I won't come out. So I tactically dodge it.
Was it PRP you were working on?
Yes, PRP, yes. That's
Yes.
my work.
Okay.
So I didn't want
Once
to start
they
talking
just say
about it. If I enter there, I have a lot to say. Some people will get confused. To
oh
balance
wow.
the audience.
Okay, that's good. That's good.
So
Okay.
the issue
Thank
of people use ultrasound, electrical stimulation, magnetic stimulation in terms of wound management currently. But the stability of the tissue generated is now an issue in some of them. So there are so many things people do.
okay.
So when you talk, such questions, when you talk on that time consent and whatever, you now talk of current trend on wound management, what people are doing currently to improve wound healing. Thank you.
Thank you. Thank you, Dr. Marshall. So thank you all. If I'll start, I'll open the post test while if there are any comments it can be happening when I open the post test. So quickly do corrections. Yes, so the answers to the questions we attempted. Which one of the following statements is true of the process of wound healing? We got number one. Dr. Ozoho, I think we got number one, that the wound healing process differs in fetal tissue. Number two, in the first 24 hours after a soft tissue injury, which one of the following represent the dominant cell type? We also got number two, neutrophil. Then number three, which one of the following collagen subtypes is most commonly found in the skin? We got it type 1 collagen. Then number four, which one of the following is true in a 6-week-old healing wound? Net collagen production is static. I'm not sure what we chose here. I can't remember. Can't remember. But at 6 weeks, they said the net collagen, because it has to balance, is static. Number five, which one of the following collagen subtypes predominates in a 3-week-old healing wound? So type 3, we got it. So Dr. Joachim, this is the answer to the ratio you were asking. I said the
Okay.
normal adult ratio of type 1 to type 3 within the skin is around 4 to 1. However, in the healing wound, type 3 collagen is made first, and this subtype predominates in the proliferation and early remodeling phases until it is gradually replaced by type 1 collagen.
Okay. Thank you very much.
Yes, thank you for also bringing that to our attention. Number 6, 10 weeks after direct closure of a wound to the forearm, what proportion of pre-injury tensile strength can be expected across the scar? 80%. Wow, this is so much. 10 weeks. Okay, at 10 weeks. Okay, so they said here, in spite of the impressive abilities to heal, tissue never regained that. A healed wound will have at best 80%, and this will be achieved between 60 days and 1 year after the injury. Okay, but 10 weeks is 2.5 months. Okay, but they still chose 80%. Okay, so I think we missed this. It's like we chose 60%. Number 7, a patient sustained a wound to the right arm following trauma. After washout in the emergency department, the wound is left to heal by secondary intention. Which one of the following is correct regarding the effect of growth factors on this process? I think we got B, because it transforming growth factor beta promotes fibroblast migration and proliferation. Number 8, cell types in wound healing. Which one of the following cell types is chiefly responsible for reducing the surface area of a granulating wound because of its contractile properties? We got this myofibroblast. Number 9, which one of the following is an important cellular process that facilitates mobilization of the keratinocyte during healing of a split thickness skin graft donor site? Loss of contact inhibition. I think we also got this. Number 10, which one of the following most accurately defines whether primary or secondary healing occurs within a cutaneous wound? How closely the wound edges are approached. We got these two. Yes. Number 11, in which one of the following conditions is normal wound healing expected after surgery? Cutis laxa. We got this. We got this. And then number 12, which one of the following vitamins can be particularly useful to help wound healing in patients on long-term steroids? Vitamin A, we got it. Number 13, which is the single most important cause of a wound to fail to heal? Poor oxygen supply, we got this. Then number 14, debridement of a chronic wound can remove excess granulation tissue and expedite healing. What else is thought to be responsible for impaired wound healing in chronic wounds that is removed during debridement? Metalloproteinases. So we got this, we got this. And then finally, number 15, you see a patient who wishes to undergo a facelift. She has given up smoking after your advice and now uses only nicotine replacement patch. Which one of the following represents a well-recognized effect of nicotine on tissues? Reduce local blood supply. We also got this. This number 16, I'm not sure we didn't attempt number 16. Yes.
Sorry, the one of the questions you asked as one of the MCQ questions said the neutral that it talked something about the neutrophils being the predominant cell type in a wood. I don't know whether it's number two. I can't really say the exact words, but I
Yes,
want
mm,
okay whether it's number okay. I wanted to know whether the predominance is dependent on the type of wound. That is, if because I know in clean wounds, maybe wounds that are created in the theater where there are no inflammation or where there are no infection, do we expect neutrophils to be the predominant cell in that kind of wound? I don't know. That's just my question.
okay,
Thank
thank
you.
you, Dr. Joachim. Please, does anybody want to respond to it? Dr. Joachim, what I would say is that once we cut tissue, we are going to damage tissue. Once we incise the skin, we are damaging tissues. It's just that the extent of damage when when the extent of damage when we have a clean wound and a dirty wound is different. You get, but as the normal process of wound healing, neutrophils will always appear first. Although we've been told that the presence of neutrophils is not a prerequisite for a wound to heal. Whether or not they are present, the wound will still progress. You get, so, but as you mentioned, it's possible that the number of neutrophils may vary in different wounds depending on the level of contamination of the wound. But whether neutrophils will appear in clear wounds, it will appear. It will appear because it's the normal. Once a wound is incised, that's tissue injury, and the response of tissues, the body to wounding, is by releasing all these inflammatory mediators. So
Thank you
thank
very
you. Please, is there anybody that also wants to react to that? Okay, so everywhere is quiet. Thank you all for attending today's meeting today. Thank you for staying till this time. We appreciate your patience. On Sunday, we'll continue our discussion. We'll do soft tissue cover of upper extremity injuries.
Thank you very much.
Yes, so I wish to see all of us, and I pray we'll find time to study so that we'll all actively participate. Good night and have a good night rest. Thank you.